electric cell.
اتفضل يا دكتور هيثم.
شكرا عبد الرحمن. بسم الله الرحمن الرحيم. We are happy today to start the scientific program of the section of pediatric urology in the Egyptian Urological Association with the first webinar. We have our distinguished guest tonight, Professor Ala El-Ghoneimi, the head of Department of Pediatric Surgery and Pediatric Urology in Paris, Hospital Rupert Dupré, Paris, France. And also we congratulate him for the new nomination to be the president-elect of the European Society of Pediatric Urology. The topic of Professor El-Ghoneimi today will be an updated management of posterior urethral valve. I'm very happy also to introduce the moderators of the webinar tonight. Professor Mohammed Youssef from Alexandria University, Professor Hani Abdurraouf from Cairo University, and Professor Ihab Rafat from Zagazig University. Actually, we are going to listen to the lecture of Professor El-Ghoneimi first, and at the end of the lecture, we are going to receive your questions through the button Q&A, and all questions will be received by moderators, and then a discussion will be made between moderators and our distinguished Professor Ala El-Ghoneimi at the end of his lecture. Now, Professor Ala El-Ghoneimi will start his presentation. Thank you.
شكرا يا دكتور هيثم, and thank you all. Of course, it's an honor for me to start the webinar series of the Egyptian Pediatric Urology section, and I can see the names around for the moderators, Haytham Badawi, and I see Mohammed Youssef, Salah Nagla, Hani Morsi, Ihab Rafat, Mohammed El-Ghoneimi. They are all now became close friends since so many years, and I am really proud of what you are all doing as a section of pediatric urology. Haytham asked me to present the I will just share the screen, so like this. If you can just make me a sign that you see it well. I think so. Yes.
تمام يا دكتور, اتفضل.
Okay, that's very good. Okay. So he asked me to share with you the management of posterior urethral valve from fetus to adolescent, because we have talked recently about our work that we elaborated recently, which are the French national guidelines for posterior urethral valve. And it was interesting because just a few days ago, I was in the ASPU and in Lisbon, and I shared in the panel of exactly the management of posterior urethral valve from fetus to transplantation. And we, of course, you will see that the guidelines were not all in the exact opinion. I will give you just the reflection of our work, and then I would love to have you all discussing our indication. This is our hospital, which is a mother-child hospital in Paris. It's a hospital which was built in 1988. We started with 500 beds. Now we're around 350 because we have increased tremendously the work on the outpatient clinic and the daycare services, which take a lot more of space. And you are all welcome to come and visit us in our new hospital. Why we're talking about the guidelines? Because a few years ago we started a national plan by the Ministry of Health in France on rare disease to organize the rare disease management, and we were honored to be accredited as the national reference center for rare urinary tract malformation from fetus to adult. And you can see this is the map of France and also the map of the other islands in the Indian Ocean and the Caribbean, which belongs to France. And so the red is our reference center as a coordinating site, and the green, which are the other reference center, which is Lyon. It was led by Professor Morricone. And just this month, we have succeeded to accredit also Marc David Leclerc in Nantes, that you know him, for also as a reference center soon. And all the blue centers, which are centers of competence, which mean that they can receive these patients in all over France, but they have many obligations of reporting and registering the patients. So one of our obligations was to elaborate guidelines, and we have chosen our guidelines. The first one, it was about posterior urethral valve. You can see all the reference, but I am sorry, it's in French, but it's excellent review of all literature, and you can see how we dealt with it. So again, you will hear the word, and you will see the word of multidisciplinary so many times, and you can see to create the guidelines. So we had experts from all the fields: gynecology, biochemistry, fetal biochemistry, imaging, pediatric nephrology, pediatric urology, psychologists, nurses, social worker, and then we worked on this, and then at the end, we give the full work to another group of reviewers to see if it's okay or not. And then we asked the families of patients to read it and to see if they can understand it or not. And especially also general practitioners or pediatricians who are not specialized at all in the field. So we started our guidelines first to get all the reference existing, which is of course the usual way to do the guidelines. So we started with 5,214 paper, and then at the end, which we really selected, it was 84 papers, and you have to be proud. There are so many of these papers are coming from Egypt, nearly from all the University Hospital of Egypt. They are sharing in these guidelines. You will see them, and number of reference was 84, and then you send to each group, as you have seen the groups, and to see if they want to add some more reference or they want to retreat the references. The first of all is this is just a summary of our first part, which is the prenatal and postnatal management. The prenatal ultrasound, if you have a urethral dilatation plus or minus megacysts, in this case, you will need a multidisciplinary prenatal care with prenatal transfer to tertiary center to discuss prenatal evaluation and management. And then in this tertiary center, there will be the neonatal ultrasound with the VCUG, suprapubic or retrograde. There is no difference in the literature, but this has to be done in the first 48 hours to do the diagnosis and the proper management. So in our center, we do the suprapubic. In other center, they would do retrograde. There is no problem if the radiologist is capable to do one of them and he's familiar with it. And we straight away, of course, that you would need, as soon as you do the diagnosis, to do renal function evaluation and antibiotic. And then you have the diagnosis of posterior urethral valve. When you have the diagnosis, either it is a premature or low birth weight. We have looked a bit in all the literature, did not find really a lot of data on it, but we had to do a cutoff, and in our institution, we have a cutoff of 2 kilograms. Less than 2 kilograms would go to incontinent vesicostomy, not to do a trauma for the urethra. Over 2 kilos, we would go to endoscopic incision plus circumcision, and eventually indwelling catheter postoperatively. I hope that you will discuss this with me, but this is our schema and algorithm that we established for the French guidelines, which of course result of all the review of literature that you have seen. Why we would do the circumcision? Circumcision, of course, is based on the work which has been done in France since years. It was presented last year in the ESPU, which was a controlled randomized study, national study, with circumcision versus no circumcision. And we found out, of course, that the children who are not circumcised, they had 30-fold of risk of infection than the circumcised one. So now it is a routine in it. And then the pediatric urology and nephrology follow-up. So this is just a summary of the principal diagnosis and management. The prenatal system, of course, what we call tertiary center. If you can see, this is the map of Paris. It is a map of Greater Paris. Greater Paris is 14 million population. And then it is divided in 4 sectors. And you can see the one sector, which you can see it here, is the north. Our hospital is here. It is the only tertiary center for prenatal diagnosis for this part. And then you have another 3 for this. And this is one of the most important progress in the prenatal management, is how to going to confirm the diagnosis and to do it. If you can see this work, that part of it was done with Osama Sarhan when he was in Paris, and you can see that the prenatal parameters according to postnatal renal function, and we can see that it's really the parameters, they are even now in 2023, they remain the same one, which are the gestational age, amniotic fluid volume, and renal parenchyma. It is very important that it is the association of all which is the more powerful in significance, but alone as a significant also you can after birth of the renal function. It is important to know that because of about the fetal intervention, the only thing we had in the beginning about the cystoscopy is fetal cystoscopy is better than shunt or not. We can see as you can see here that the fetal cystoscopy significantly improved renal function, but the shunt itself did not improve the renal function. But the most important, of course, that the fetal cystoscopy or the shunt improved the survival rate. This is the main conclusions of all the fetal work. But of course, there is some controversy and some reserve that we are doing to this result, that the normal renal function only taken to do this conclusion is 6 months of age, which of course is not the same. Second thing, that they compared the fetal cystoscopy with a shunt with 2 departments, one in the States, which is Roanoke in the south, or he was in Brazil, and then now in the south of in Florida, and then with the shunt in Strasbourg in France, with a difference of nearly 20 years between the two, which means that, of course, the patients are not the same, diagnosis is not the same, and the neonatal management is not at all the same between the 90s and 2013. So you have to be careful with the conclusion. So they did not provide long-term follow-up regarding renal and bladder function. That's why it is not really a powerful study for it. That's why there is a valid parameters to predict the postnatal terminal renal failure are the age of gestation at first diagnosis, the amniotic fluid, if you have an early oligohydramnios, not late third trimester, the fetal urine and or blood analysis, and the renal parenchyma, significant anomalies like cysts, for example, in the parenchyma. Fetal surgery, hope for improvement only in cases of early intervention. You have to do it nearly early second trimester. So, of course, we are still waiting for a strong prenatal parameters to clear the gray zone. So the prenatal intervention still today has to be restricted to highly specialized tertiary center for research, clinical research protocol, prospective protocol, because the results are not sure yet. So now, if you have a newborn with posterior urethral valve, can we predict the end-stage renal disease? So many old publication, recent publication, they are nearly the same. Again, here is an excellent paper written by the two departments, a joint work with the Department of Mansoura and our department. And it did now, but it's still the same, which is the nadir creatinine 7 days after relief of obstruction and at 1 year. If you have it less than 80 micromolecule, you can expect good prognosis, but good prognosis, which means there is no renal failure in early years of life. But if you have more than 80 micromole, it's sure that this child, unfortunately, will have end-stage renal disease. So you have to prepare him, even if he's having just 80 micromole or 100, that he will have renal failure one day. So you have to prepare him for this for nearly all his lifetime. That's why neonatal management is important, to be multidisciplinary with a prenatal diagnosis, as we said, We're repeating again, prenatal mother transfer and neonatal management. There was a lot of publication in the 60s about the high diversion, pilostomy or uterostomy. I'm talking about the high one. Goals was mainly survival rate and renal function and somatic growth. The disappointment is the long term. No improvement of renal outcome. Poor bladder function correlates with high diversion. If you do, of course, bilateral high diversion. 30% of highly diverted bladders required augmentation in these studies, and 4% only of undiverted bladder required augmentation. That's why there was this technique of sober ureterostomy, which is the optimal diversion to avoid bladder dysfunction in this case. You can do it unilateral. And also now we had discussed in the panel in the SPU, there was a bit of discussion now about why not doing inguinal refluxing ureter loop ureterostomy. We don't do it in our institution. We feel that we don't have any proof, but this can be a good idea if you cannot handle, of course, the metabolic disorder of the child, or you want to improve his urinary output. In the low diversion is vesicostomy. Of course, published by Duckett 74. The advantage of it that the bladder fills and contracts, and it is easier reconstruction than supravesical diversion because you don't need to re-implant the ureter or to close any ureterostomy. Again, there was some publications in the beginning of this in 2004 that compared early endoscopic section to vesicostomy, and it is 2 years follow-up without any difference between both. So endoscopic incision, what we call before valve ablation, there is a huge technical progress. That's why also the way to do it is different now, since all the progress in the miniaturization of the pediatric endoscopes and the improvement of light sources. So really now the BAC-B3, the monopolar on metallic ureteral catheter, all of this now should be abandoned for the sake of cold knife incision, or the laser if you have the possibility. But of course, all blind method should be totally abandoned because there is no place for it now with the new technology. The principle of it, you see that this is a paper from Alexandria with Muhammad Yusuf who did it. And with that, neonatal valve ablation would protect the bladder and allow normal cycling, which helps in bladder healing. And this underscores the importance of routine prenatal screening and early intervention at a specialized center. Early valve ablation can decrease the incidence of bladder dysfunction in boys with posterior urethral valve. There is no specific technique for it, but it need to be done in a highly specialized center. We have to reduce the urethral trauma, the operative time, and the bladder irrigation to be sure that you don't have any hypothermia or metabolic disorder with these children. It is a specific surgery, short but difficult one, which is really to be supervised by senior pediatric urologists. We keep this exceptional indication, as we said in the algorithm, for vesicostomy. It is exceptional. In our experience, it's not more than 4% of the cases would need vesicostomy. And of course, the technique of valve ablation, if you use diathermy, you can start to have this major complication of a structure that the incidence was in this study. It was using the resectoscope for it with the loop resectoscope, which can really damage the urethra more. We have to avoid aggressive endoscopy, which means that if the surgeon has not the equipment to do a neonatal cystoscope, in this case, we should not do the valve ablation. We'll do a vesicostomy and do it, or send it later on to a specialized center. This should never be seen, honestly, as we can see this case here with an aggressive endoscopy for valve, ended up with endoscopic resection and total stenosis of the valve. And of course, this complicates a lot the life of this child who's having already a valve bladder. And then you add, as you can see here, a total necrosis here and stricture of the bulbar urethra, just the subprostatic urethra here, because of an aggressive endoscopy and aggressive resection. And then you did it well. This is nearly mostly the only surgery that you would do. That's why it's frustrating for pediatric urology, but it is the only thing which is nearly half an hour of endoscopy. After that, you have to do an active follow-up and multidisciplinary follow-up for nephrology, for the nutrition, hydration, renal failure management, and for the urologic surgeon and nurse is scintigraphy with DMSA, ultrasound, and then when he's growing up, the post-void residual and the flow meter. When can we have to go more aggressive? If you have renal function deterioration, persistent or increasing upper tract dilatation, there is a weak stream noticed by the parents, febrile UTI, or incontinence. In this case, we need to do urodynamic. If you have the chance to do video urodynamic, it will be pertinent because more than half of these patients, they have reflux at the same time, and you need to know if this reflux, is it a high pressure, is it a low pressure, how is the morphology of the bladder, and the morphology of the bladder is important in the evolution of valve. If you see residual valve or iatrogenic structure, in this case, we will need, of course, void excistogram if you did only urodynamic standard one. But if you do video, you wouldn't need it, and then you go for endoscopy, second look, and management. The video urodynamic would lead us to do the diagnosis of valves bladder. Valves bladder, there are three types described, either vasosphincteric dyssynergia. In this case, we can propose without a lot of evidence, either alpha blockers and anticholinergic, or it's a hypocontractile bladder. In this case, what we would need, or the third one is hyperactive high pressure, which is the most dangerous valve bladder. In this case, it will be anticholinergic, but the three of them, dyssynergia, hypocontractile, or hyperactive, they will need the CIC plus or minus night drainage for it. We advocate for CIC by the urethra. If it's a sensitive urethra, you need to take your time to educate the family and the child. And if it's not working well, it will be CIC through a Mitrofanov. And then after, it will become the problem of incontinence, which is really a bad term for it, because it's not really insufficiency of the sphincter. It's always secondary to something. The primary valve ablation allows bladder cycling without obstruction. And urinary incontinence has been a common problem in boys after valve ablation. in our series, which have been again confirmed by a new work after this old work of 2008, we can see over 55 patient toilet trained, where 20% of them, they were wet day and night. And for their bladder function, again, the loss of compliance is less frequent than bladder instability and bladder megacystis with myogenic failure. The most severe cases requiring CIC or bladder augmentation, they were only 4.6% of the study population. That was in a population long-term on 55 patients with valve. But we have to be very prudent and very critical to diagnose early valve bladder syndrome, which are the small, poorly compliant bladder after valve ablation, which was described by Mike Mitchell. And this will be with a severe or persistent severe hydronephrosis without residual or recurrent obstruction. So there is no anatomical obstruction. It is mainly non-compliant thick wall bladder, urinary incontinence, and acquired nephrogenic diabetes insipidus, which is a severe polyuria. The valve bladder syndrome, which was a bit explained by Glasberg, now 20 years ago, it was that the polyuria, poorly compliant bladder with stretch injury of the bladder dysfunction, back pressure on the bladder, and renal tubular dysfunction, so which will lead to polyuria, and then you have this vicious circle that you need to break this vicious circle during work. That's why there was this idea of doing the overnight drainage, which will lead to decrease the sustained bladder. And you can see in this work, it would show that impaired bladder sensation in very frequently in posterior valve patient, and treatment of overdistension during daytime alone was unsuccessful because, of course, nocturnal bladder, it will, for 10 hours, this bladder is fully distended by the polyuria. And in this case, this work in the beginning showed that hydronephrosis markedly improved once nocturnal bladder emptying was started and was comparable to the result after urinary diversion, which this is important message that instead of going to surgical diversions, think of CIC and night drainage. Renal impact of it is not sure. 24 patients with valve bladder syndrome, follow-up 6 years. And the hydronephrosis and overall bladder function improved, capacity and compliance, but end-stage renal failure developed in 35% of cases, which are nearly the same rate of doing it. But maybe it will delay the end-stage renal failure, which is a very important also factor for this patient. In adults, that was this long-term study by Paolo Caioni in Rome. You see that in the adult patient, when you leave the children to go to adult, you have 54% of renal failure and 29% of bladder function. So the bladder dysfunction remains an important problem in adult. You cannot say that with the development of the child with adolescent, this bladder dysfunction will go. No, bladder dysfunction will remain, but it needs follow-up, and of course a proper management. But renal failure and other, you see in all the children series, we will talk about 30% of renal failure as when, if we talk about adult, it will go more than 50%. So it's a lifetime workup. As you see, this is the Sweden, also the Sweden by Holmdahl, Gondela. 40% they have in adult, they have signs of dysfunctional bladder secondary to over-distended bladder, which is mainly the myogenic failure. So a lot of these people, children with bladder function, have never been investigated with urodynamic study, which really, it's very important that we have to go more aggressively when we start to see any signs of decompensation of the bladder. And the bladder dysfunction is also related to end-stage renal disease. As you can see with the work of Lopez Pereira in Madrid, that 9 of the non-compliant bladders ended with 8 end-stage renal disease. And even the myogenic bladder end with end-stage renal disease also, but just unstable bladder is 25% only ended in end-stage renal disease. So it is preventive treatment or therapeutic treatment. If you have a non-compliant high pressure bladder, we need to confirm it by urodynamics. And we need to go an aggressive early treatment, anticholinergic, alpha blockers, and CIC, preferable by the urethra, but if not, metrophenol. And then the critical question of bladder augmentation for this patient. It should remain exceptional. There are some restricted criteria: low compliance, progressive deterioration of upper tract, even with CIC and anticholinergic of high dose. We need to take our time and do the maximum to avoid it. Preventive early medical and CIC management for these children. But whatever type of bladder augmentation, all long-term studies had shown significant high complication rates up to 50%. All the type of augmentation you would do, in the beginning they are nice, but at the end they end up by complication. And then you have to add the proper specific complication of posterior urethral valve patient, which are renal failure, transplantation, the immunosuppressive therapy. So all of this will add more complication to your usual bladder augmentation that you do. The other one are the myogenic failures. They are less risky for the high upper tract, but they can give urinary tract infection and incontinence. In this case, the treatment would be again to empty the bladder with a CIC. When they go to renal transplantation, as you can see that it's a high rate, will go to renal transplantation, you need to do an aggressive bladder workup. Detail the clinical voiding calendar, cystography, flow meter, and urodynamic. If you have video urodynamic, it will be okay. Major difficulty in boys if they don't have urine output, especially if you have done already bilateral nephrectomy or they have a urine output after dialysis, which is nearly nothing. And cystoscopy, if you don't know this patient, first time to see him, you have to do cystoscopy also to do the diagnosis to see if there is any residual. We need to start with the CIC and anticholinergic, urethra again. If you cannot, you do metrophenol. The exceptional indication, as we can see, is bladder augmentation, but think of doing things else like a ureterocystoplasty, if possible. This can delay also the transplantation, but if you are in front of a transplantation and you don't know if you want to do bladder augmentation or not, so try the ureterocystoplasty with metrophenol, and this can work as they are borderline, which may improve after transplantation. as you can see that when you have a patient with posterior valve and the bladder augmentation, you have higher rate than other patient than posterior valve without bladder augmentation. Infection, stenosis, bladder perforation, stones, they are much higher, and especially that there is a significant increase in UTI after transplantation in patient with posterior valve and the bladder augmentation. This is our recent cohort study of renal transplantation with posterior valve. We have done the study on 26 patients with follow-up, median follow-up is 11 years. And we can see that they are a group of 3, as usual, for the posterior valve patient when they arrive transplantation. Group, there is no lower urinary tract symptom. In this case, they are like other patients. There will be nothing to be done especially. Or the one which they requiring medication, or the group, which is a big group, 10/26, which they have major bladder dysfunction, which require medication and CIC. We will have the 2 groups, which is the low compliant, hyperactive bladder, or the myogenic failure. This is a true urodynamic. I can really, you have to believe it. This is before transplantation of this child, and this is after transplantation. You have the polyuria was decreased. You have the treatment whose medication is better, and the treatment was in the beginning CIC exubutinine before the transplantation for hyperreflexic poor compliant bladder, and it is not just one case report. We can see that we have to stop. We usually stop the CIC 1 year after if you start to have this urodynamic after transplantation. I will show you this also. This just one case. This child is coming, he never had urine in his bladder. He was anuric when he was born, early infancy, stage renal disease. And when he came to age that we need to do transplantation, he was 3 years old, 4 years old. And then we can find here, he was having a bladder of 16 ml with a very high pressure, as you can see here. So a very high, low compliant bladder with small capacity. Don't go and rush in bladder augmentation straight away, because if you do what we call bladder stretching, 3 weeks of continual perfusion of the bladder, that was in July, that is in August, before the transplantation, we have a 180 ml of bladder capacity with a good compliance equally, which of course it need a lot of work of preparation for 3 weeks, but at least avoided the bladder augmentation. So please do not underestimate the bladder. If you have, like this patient, missed posterior valve and is coming to you by another center for transplantation as this child, you have to do cystoscope, and you have, this was having a valve, and he was sent also multiple operated child with destroyed bladder and destroyed kidneys and bilateral reflux in the beginning, and then remained one kidney like this. So in this case, you would do the left nephrectomy and CIC by the left ureter, by the left ureterostomy, and posterior valve ablation. And then after that was pre-transplantation, that the pressure started to increase after 330, and you can see that after transplantation, it started to increase after 440. And in this case, you will just stop the CIC, and you can abandon the ureterostomy, or you can remove it even if you want. It's an easy surgery when it's just a ureterostomy. So in our conclusion that in 7 patients over 10 in this high group of risk for kidney transplantation with valve bladder, you can see that the 10 over 10, they had no more polyuria after transplantation. 7 patients over 10, they stopped doing the CIC. They still having infection. We have to be careful with this. And there is no more medication for 5 patients over 10, and only 3 patients which remained with CIC, oxybutynin, and alpha blockers. So this is important message that you need, of course, to follow them up after transplantation. And of course, if it resists the bladder, having a low compliance, of course, you need to do a bladder augmentation afterward. So bladder dysfunction improved, disappearance of polyuria. So please reconsider bladder augmentation before renal transplantation. So to conclude, first, that early valve ablation can be considered as the primary treatment in majority of cases. Endoscopic treatment is feasible safely in the neonatal period if specific pediatric cystoscope with experienced surgeon. Second conclusion, that surgical procedures are minimal during the life of these children, but we need to do an aggressive early bladder management because there is unpredictable bladder prognosis. It could have possible long-term improvement if you avoid any early bladder surgery like reimplantation, like nephrectomies, like all of this surgery. In our the only conclusion that we made officially, because this national protocol for valve, this is an official one with the authority of high authority of health in France, that this our recommendation, which they have a legal recommendation that at each step, each age, multidisciplinary management is a must. To optimize follow-up and inform as complete as possible the parents, medical staff taking care of the child. Any fetus diagnosed with lower urinary tract obstruction should be referred to expert prenatal diagnostic center. In prenatal, any suspected pseudocell valve should have a multidisciplinary consultation, not only obstetrician. It has to be with neonatologist, pediatric urologist, and nephrologist. And this consultation must be proposed to expecting mother, and decision is to delivery and the neonatal period should be organized in a tertiary maternity center, because you give an optimal care if you can start as early as possible with this child. Thank you so much, and I hope it's not too long for all of you, and I'm happy to listen to any questions or critics. Thank you.
Thank you, Dr. Ala, for this detailed and comprehensive lecture, as usual. I will leave you with the moderators for the questions. But first, I will ask a question. What are your strict indications to start CIC? I followed the lecture carefully, and I know you have said when persistence of upper tract dilatation, whenever UTI starts, whenever incontinence, whenever the flow is weak, and all these indications will call for considering video dynamics and then the decision for CIC or not.
Yes.
What are the criteria to start CIC? Because we sometimes see patients with persistent hydronephrosis, but they are not deteriorating. Creatinine is stable, and they are stable, not showing UTI, but the upper tract is not improving like what we see in other children. What are strict criteria again for the CIC? And if you do nocturnal CIC, you do mitriphanol, or you do nocturnal CIC per urethra. You taught us if we do nocturnal CIC, we do mitriphanol. Am I right?
First, for the criteria, urodynamic criteria is very difficult, honestly, at this age. That's why we start now a prospective study to do prospectively urodynamic for all the patient early at 3 months, 6 months, and to see if really what is the natural history of this urodynamic. Now, right now, it's a national study. But because, of course, you can see hyperactivity, you can see low compliance, and see all of this. But the main thing is the multiple factors. If you see the hydronephrosis, it's still very important, which means that the parenchyma is thinning more and more. You have the ureters that you can see them dilating more and more. The child is dribbling, nearly dribbling, not really voiding. Infections, we have to be very careful because infection proved one with high fever and all of this needing hospitalization. All of these are criteria for to do not just because if you have a very high compliance, which means myogenic failure, you will need it, or you have very low compliance, also you will need it. So it's really depends on the manifestation more than something else, which is progressive dilatation, for example, it's not mine. Second, for CIC, for us, whatever you will put, night drainage or day, we would do urethra. Okay. And then if it cannot, we will go to metrophenof, even for the night drainage.
Okay. Thank you.
Dr. Allah, thanks for this nice presentation. There are many questions. There is a question about CIC. Is it appropriate for young boys, as urethral injury is pretty common on those patients, and is suprapubic catheter with regular bladder emptying is valid alternative? ده سؤال من دكتور محمود.
What is the regular what?
Suprapubic.
Repeat the question you have.
Yeah.
Can't understand the question.
The question is CIC appropriate for a younger boy, as urethral injury is pretty common in these patients, and is suprapubic catheter with regular bladder emptying is a valid alternative?
I understand. Suprapubic catheter should be a temporary solution only. I mean, just for 1 or 2 weeks or 3 weeks, but not more. Why? Because these children should not have multi-resistant microbes in their system. After that, it is very difficult to get rid of it. If you want to do a suprapubic, do a vesicostomy or metrophenof, but not. Second, for the small babies, small children, I mean, the indication for catheter, we would not do it in babies. For the CIC, we would do it later. But we start early. We have one, we started today in the morning. He's 2 years old. I mean, you can start, but it's a full system. You don't have trauma if you have the system, which means I am sure if it is done by the surgeon, it will not work. You need to have somebody dedicated to it. Of course, I know the difficulty in many countries and in Egypt also, which is to have a nurse, dedicated nurse to do this work. It takes us exactly 12 hours to educate CIC. 12 hours, which means 4 days, 3 hours per day, that they come to the outpatient clinic to do. But at the end, we don't have failures. We have to shift to metrophenof. Metrophenof only if you have really either a false passage, you are already, because he has passed in many departments where he has a false passage in emergency room and all of this, or it is impossible. I mean, for the family, it's impossible. In this case, we would put him metrophenof.
علاء في كذا سؤال. أنا هاني مرسي. في كذا سؤال حوالين الفازايكوستومي. I am happy you are returned to vasectomy, even in one indication that the child or the infant is less than 2 kilograms.
Yeah.
Why you return to the vasectomy to small babies? And there is many questions about extending the indications for vasectomy to patients with sepsis or high creatinine level. You accept that?
Of course, you need, anyway, if sepsis, uncontrolled sepsis, you have to divert. But if you want to control sepsis in a posterior valve patient, urgent vasectomy will not help. I mean, you need to put percutaneous nephrostomy in this case. If it's a problem of acute sepsis, but if it is a chronic, I mean, repeated, recurrent urinary tract infection, febrile urinary tract infection, of course, the vasectomy will be of help. Why the other question, why we say 2 kilos?
Why you return to vasectomy in babies less than 2 kilograms?
Oh, we never returned. We always have done this. Because a child who is 1 kilo 800, what kind of cystoscope you will put in?
And
So
in
in this case,
and in babies with high creatinine level, you recommend
for us it is not helpful, the vasectomy. For us, I mean that if you have to take the decision for the global status of the patient. We would go first for valve ablation. And if the creatinine is high, but you have to look to his kidneys and his history prenatal also. If already the kidneys are bad, parenchyma is bad, full of cysts, whatever you would do, they are like this. But if he cannot control his metabolic disorders, you need to divert, of course, in this case.
دكتور علاء، ده انا محمد يوسف.
أيوة.
معلش انا عايز بس اوضح نقطه الفيزيكوستومي، لان انا يعني برضو كنت انترستد فيها جدا. ايه راي حضرتك انه احنا we have two types of vasectomy, a primary vasectomy دي اللي حضرتك اتكلمت عليها especially for the prematures. انما I like the term of a secondary vasectomy when you have a child and you have an infant and you did a primary valve ablation and you are not happy, and there is a pressure from the pediatric nephrologist and pediatrician that we have a recurrent febrile UTI, and then you don't have any other mean unless to go in again and do vasectomy in an infant that you did a primary valve ablation. So do you have these kinds of...
Yeah, of course. Of course, this is one of the indications. In this case, you have either vasectomy, either sober ureterostomy, but low ones. I mean, we don't do any more high diversions.
Totally agree.
And but you have to do something. But I can tell you honestly, these patients are very difficult to manage.
Yes,
Even
yes.
if you divert them, they still keeping infection. When you divert, still keeping infection. But again, you see the expression you said, the nephrologists are pushing us to do it.
Exactly.
Yes, but if that child from the beginning is managed with both, I mean, with both, there is nothing called nephrologist will push me, which means that he is phoning you to tell you,
yes,
Dr. Muhammad, you have to come to divert him. I want you to divert him. No, it is a meeting, disciplinary meeting. You see all the cases and discuss too.
قبل ما اسيب حضرتك انا بس عايز one point على الهايلايت of the urinary bladder stretching at home.
Yes.
Do you think it's feasible? يعني انا عارف ان حضرتك عندك a very good experience in transplantation of these kids. احنا بقى في اسكندريه دلوقتي بقينا بنصادف ولاد بعد ما تابعناهم انا وهيثم والزملاء في الوحده عايزين ترانسبلانت، والبلادرز زي ما حضرتك قلت كده they are not that good. احنا مش قادرين نعمل لهم a good management عشان نكنترول البلادر behavior، والامهات عندنا في مصر متعبين، ما بنوصلش لجود stage of bladder control قبل transplant.
Okay, so what you are going to do?
ما انا هبعتهم لحضرتك بس نفسي
No, you cannot. No, I mean, you will. What is the other solution? Is bladder augmentation. That's right. Okay. How can you trust a mother that she cannot just to do CIC or think in a child who's not already transplanted, is not under immunosuppression, and you will trust her to manage bladder augmentation
Yes, yes, yes.
and immunosuppression and the transplantation.
Sure.
This is the thing. I mean, it's a very complex. There is, I mean, believe me, your mothers are very good.
Mm.
It is just that time allocated to these mothers. If you stay with this mother
The question,
long,
Dr. Ala, is bladder stretching works in all bladders, or it is variable from bladder to bladder and from valve to valve and from obstruction to obstruction?
We do it systematically. We had one case, of course, we had one case, you're right. We had one case who could not do the stretching. I mean, we put it, especially the old ones. When you have a one who's having 10 years of pathological bladder anuric, of course, it will be more difficult because of he will not tolerate the stretching.
We have a study for these bladders after renal transplantation.
Yes.
For the effect of renal transplantation on bladder function. And we have found that in patients with defunctionalized bladder, without pathology, without posterior valve or without neurogenic bladder, they improve their both bladder functions. The storage function and the emptying function will improve. And in patients with pathologic bladder, neurogenic bladder or valve bladder, they only improve their storage function, but their emptying function still deficient. And this is also very important to us in our protocol for these children with bad bladders. We postpone the decision of augmentation after renal transplantation. These borderline bladders, we just counsel the parents so that the child may need augmentation, and there is a risk to do the transplantation in this bad bladder. But if the bladder does not improve, we will do augmentation. And in our series, in the posterior urethral valve patients, only three patients from 300 patients needed bladder augmentation after renal transplantation. But still, there is a rule for anticholinergics and CIC and the tumor bladder empty.
Of course, I think you are confirming exactly what we are managing. Dr. Hani, you are really, I mean, I don't know if you published this work or not, but it is very important.
We published data in the pediatric.
What about your abstracts that you mentioned in the presentation? It is not yet published as a manuscript?
Unfortunately, I'm going to kill the fellow after.
I have a very good question from Ahmed Zakaria.
Yes.
He in extreme cases presenting with forniceal rupture and ascites after cystoscopy and ablation, other than he leaves the catheter slightly longer. Any other early measures for these patients with ascites, urinary ascites?
What is the reason for urinary ascites?
He presented with urinary ascites due to obstruction.
Yeah, I know, but is it by
high pressure,
rupture bladder, or rupture calyces?
That's it.
Calyces,
Calyces?
Yes.
Forniceal rupture.
Most of the rupture calyces, they are good prognosis. I mean, it's a good ascites. What we do, of course, you have to drain him, but you have to drain after valve ablation again. We start always with valve ablation, but this is just, I think this is just a personal belief, and that we kept it, and we compared in this review all the series. There is no difference. I mean, if you put a catheter for 1 week before the valve, or you leave it after the valve, for these special cases, you can put a catheter after valve ablation for these cases, of course.
دكتور
In our
علاء
experience,
في
Dr. Ala,
multiple
urinary
questions.
ascites has a very bad prognosis. The patients with urinary ascites, it is not a pop-off mechanism. In our
No,
experience,
you have two kinds.
patients presented
I'm
with
sorry, you have two kinds. Maybe I expressed. You have two kinds. You have the urinoma, unilateral urinoma, which is a good prognosis of pop-off. But of course, ascites, pure ascites, of course, this is a bad prognosis.
And in these patients, we do vesicostomy from the start and even drainage for the urinary ascites, but the prognosis is very bad in these children. This is the question of Ahmed Zakaria.
Yes, he is right. And this, of course, those are one of the rare cases that you can do vesicostomy from the beginning. But I mean that don't do valve ablation and vesicostomy. Of course, you are all agree about that. You don't do at the same time vesicostomy and valve ablation because of complication of the urethra.
دكتور علاء في أكتر من سؤال على appropriate age for video urodynamics and for Mitrofanov. Which age you can recommend for video urodynamic and
video urodynamic, when it's indicated, I think you can do it whenever you do. But the question is why you're doing it, what question you are doing. Most of the time it will be, you want to know if this refluxing bladder, for example, is it a refluxing bladder with high pressure or with low pressure? If it's low pressure, you are more keen, you are more patient with the patient. But if it is a high reflux with high pressure, which means that the compliance is very bad, in this case, you will go to discuss the CIC, you will go to discuss the vesicostomy for this patient. For the age, I think that we can do it at 2 months or 3 months, even of age, you can do it. But we don't have the answer, what is really the physiologic urodynamic at 3 months, honestly.
Ala, I need to ask you something. After you have done ablation, do you have a routine check VCUG or endoscopy, like a month after your ablation, or you depend on the clinical evaluation of the infant?
The routine one, when there is what we would say guidelines, routine one is the VCUG. In our institution, it was always VCUG since 30 years. And then 1 year ago, we said, okay, why doing the VCUG? So we took all our patients who are done VCUG to see did it change our indication or not. It did not really. Because when you routine, no. There's always something for a residual valve, you always have something.
Clinical something, yes.
Something clinical, something. After that, second look systematic without video urodynamic, a lot of controversy. I cannot say it is bad practice. It's not a bad practice because there are so many departments are doing it. Very well known and well structured.
Yes, I know that.
They do it. But I really personally don't agree with that because there is no, you will always find something when you do the second look.
Yes, correct.
There are 3 questions about.
Yes. دكتور إيهاب أو دكتور هاني في إذن طلع فوق.
We have many questions about the bladder neck and posterior urethral valve. What the dose you use as alpha blocker in these patients? And if you have the syrup, or what the dose exactly for these patients? And do you perform in your institute bladder neck incision for these patients?
Okay, for the alpha blockers, we use what everybody's using. I mean, it is on what we call it la cuisine, يعني الطبيخ يعني. you take a dose which is 2.5 milligram, you will give it to the child. Is it good? Is it bad? Nobody knows. Unfortunately, nobody knows. There is many studies now going more and more on alpha blockers, and I think you have to prove it. There is one study came from Egypt last year, but it needs to be really proved that in a good way, good methodology, that it works, the alpha blockers, because there is nothing which is innocent in treating these children as medication. The other thing I never understood, if somebody can help me, I never understood bladder neck incision. What we are incising. I mean, are you incising the mucosa or you are incising the muscles?
You know, the muscles.
Of course. If you
Mucosa
are
and the muscles deeply.
when you do, we have even the approval that when you do a huge detrosotomy, it does not work very well. This is a detrosotomy, what you're doing in bladder neck. I mean, you are doing incision, you are cutting muscles which are hypertrophic, only in 5 millimeters of muscles, because you're not really cutting it all. And either you are very reasonable, you don't want to do scars and all of this, you will do a very superficial incision, which will just heal in 48 hours and then nothing happening, or you will do it very deep.
Aggressive.
In this case, of course, you will risk having complications of bladder neck incision, which are incontinence and all of this. But I think personally in our institution, we don't recommend it at all. In the panel in the ASPU just 1 week ago, I was saying this, but because it was South America against Europe, I mean, and the South Americans, they using, especially in Brazil, they use it when it's persisting hypertrophy of the bladder with persistent dilatation. It is nearly the same indication as CIC for them.
There are some urodynamics parameter in the literatures, especially done by Glasper, the paper that you mentioned for the Glasper. And when he did urodynamics, he had some parameters indicating that there is a bladder neck obstructions in these valve bladder boys. That's why the attention to the bladder neck came after some detailed urodynamic analysis of the pressures.
Yeah, of course.
And he had a lot of equations.
We don't have a strong result.
Yes.
In the literature.
And I think there is no need for this.
What we know about valves now after so many years with so many patients is that it's a multifactorial malformation.
Yes.
And when you compare, you cannot just compare incision with not incision. You have to put the factors of reflux, infection, renal function, bladder capacity.
When you go in again in those boys who are not well, you will see the posterior lip is very high like this. So it's very tempting to have your knife and do your incision, but I don't recommend doing it actually.
There is Muhammad, many times Muhammad Al-Ghanimi raised his hands and then he put it back.
No, I was just waiting to answer a question. I know it's a repetitive question regarding the cycling of the bladder prior to transplantation to improve its capacity. Just a question about this cohort of patients.
Bladder stretching.
Were these patients anemic patients, or were they normal voiders but with a bad capacity and compliance?
I think there's maybe a confusion. The case which I presented was just one case. It's not our cohort, was all stretching. The stretching, we use it only for anuric patient.
اللي هي defunctionalized bladder يا محمد يا غنيم.
Because
anuric patient with a small hypocompliant bladder, and you are thinking of what to do. Is it, for example, for this child, I had the kidney just I had a kidney for him, and it was exceptional. So before preparing the bladder, so we accepted, and I put it in Precare at that time. And then we said, why not using the bladder after? And then we started to cycle the bladder, and then we saw that the bladder, we can use it. And we put for him the second transplantation, because the first one did not work, had thrombosis. We had to put it in the bladder.
Okay. Because I'm just seconding the opinion. Hello?
Very exceptional patient that you need to put a bladder augmentation in a child who is 2 years or 3 years old. And in this case, of course, you are very worried about it. So in this case, either you do a Precare or you would try to do something like this. And the stretching it has been published, not by us, it's published by others. The most important is not to infuse the bladder, perfuse it with a high rate perfusion. You have to put it with the urine output at his age, which is very minimal. It's drop by drop. So like this, he will not straight away cry and want to empty his bladder, because it will be very painful if you put a big volume.
I still can't understand how it's done, because this is done at home or in a hospitalized.
Okay, so the protocol exactly that the child, we put him under general anesthesia. We do the cystoscopy because the bladder is very small. You cannot really do it without it. And under cystoscopy, we put a 5 French catheter, suprapubic catheter, but it is a true suprapubic catheter. It's 5 French. You put it to the bladder, and then you connected it to here we have the pump, which is 24-hour syringe, electric pump.
Infusion
and
pump.
Then for 2 days, he is in the hospital. 2 to 3 days he's in the hospital to start this treatment. As soon as everything is good and the family can start to do it, they go home with it. And of course, they come back 3 weeks after, and then we do the video dynamic 3 weeks after.
Okay.
إذا سؤال على الفازايكوستومي يا دكتور علاء. Delayed vasectomy for management of valve bladder syndrome. Do you accept delayed vasectomy for management of
At what age? At what age?
مش قايل at what age يعني.
But anyway,
قصده يعني أكيد بعد 2-3 يعني.
Yes, I think if you cannot do CIC, you have to do it, because this is the least bad thing to do it. But if you can do CIC, it will be better.
Another question to علاء محمد الغنيمي برضو معلش sorry is that you mentioned that you might attempt going for augmentation urethral cystoplasty prior to augmentation with a segment of an ileum.
Yes.
I don't know what your experience with urethral cystoplasty is, but unfortunately our experience in Cairo University is so bad that we stopped.
Very bad experience with urethral cystoplasty.
Because it does not give really much capacity or compliance to the bladder.
Exactly. But for how? I mean, you have to put things. For a patient who's 2 years old, we're talking about this kind of patient. 2 years old, nearly bladder failure, end stage renal failure, but he's not yet in the stage renal failure. You want to increase a bit his bladder capacity, the compliance, and you don't want to lose his bladder. You don't want to do augmentation. And he has non-functioning kidney with severe reflux in it. So we have a patient exactly like this. And he was a candidate for bladder augmentation somewhere else. And he came to see us he was 4 years old. Now he's 9 years old. And we just pushing the transplantation and end-stage renal failure a bit. Maybe at 10 years old, he will need a true bladder augmentation. Maybe. The same thing for neurogenic bladder, we do it also. I mean, it's not always working, but when it works, it will push you.
هو الحقيقه يا دكتور علاء احنا عندنا جود اكسبيرينس بالاليوسيستوبلاستي في الهاي كرياتين ليفل، يعني اللي هو سي كي دي يعني جريد 3 2 و 3 وفي السمول ايج كمان، ان هم بيحسنوا يعني بيحصل تحسن في الرينال فانكشن، وبنقدر نديلاي برضه الاند ستيج رينال ديزيز بالاليوسيستوبلاستي. وده الكلام يعني دي كانت رساله وهتنشر قريب، يعني ان احنا قلبنا جامد قوي على الاليوسيستوبلاستي مش اليوتروسيستوبلاستي، حتى في العيانين السكي دي جريد 2 و 3 والسمول ايج اقل من 3 سنين.
هو استكمالا لكلام هاني يا دكتور علاء، على فكره احنا الاكسبيرينس ده we did not gain by choice، احنا we were forced into it. احنا في الاول كنا ملتزمين بالانترناشونال ليترشر by avoiding early use of helium سواء في الايدج او مع الرايز في الكدني فانكشن. بس زي ما حضرتك قلت كده، حضرتك التشويس احيانا بيبقى فيه اطفال you don't know what to do with them. احنا عملنا نفس اللي حضرتك advised، اللي هو we opted for الاول urethral for going on vasectomies, incontinent diversion، كل الكلام ده، وفي الاخر we attempted ان احنا نجو for urethroplasty at younger ages و at higher grades of CKD. وبصراحه ما لقيناش ان هي reason for deterioration. هو ما فيش data published for reason for deterioration واضحه، لكن احنا ما لقيناش ان هي reason for deterioration قوي يعني.
بالعكس كان الريزلتس كانت كويسه كمان.
We don't.
أصغر
If
سن
you have
كان
a good nephrologist, you will not have metabolic disorders in bladder augmentation. But you just told me, Hani, that if I remember very well, half an hour ago, that you had only 2 bladder augmentation with valve.
3.
So how we are doing 3, and then you have a great experience with bladder augmentation before transplantation.
Maybe for the other
Not for the
valve.
Not only for the valve. Not only for the valve. Only 3 patients needed.
Yes, but
in urogenic
valve patient, yes, but valve patients are extremely different from neurogenic bladder patients.
Yes, I totally agree.
True. This is quite true.
This is true.
They are not the same category. That's why I'm not talking about neurogenic bladders.
Exactly.
Of course, if you have a neurogenic bladder, it's a definitive final status of the bladder, bad bladder. It is done. I mean, there's no way that you're going to take it back. But valve bladder, they are not the same thing as you never have myogenic failure in neurogenic bladder when they are hypertonic. When they are hypocompliant, the valve, the bladder, neurogenic bladder, they never change in lifetime. They will be more and more rigid and more rigid. But valve patient, most of them, they will change to a hypocontractile bladders. You agree with that or not?
We agree.
True.
Yeah.
Agree.
So when I'm talking about ureterocystoplasty in valve patient, not in neurogenic bladder.
هو ده السؤال بالظبط حضرتك، restricting اليوتروسيستوبلاستي للفالف patient.
Yes, tonight we're talking about posterior valve patient. You paid me to talk about posterior valve patient.
There is a hypothetical situation. A valve child, 5 years with still a vesicostomy, and he needed a kidney. Would you transplant a kidney with a vesicostomy opened? Because I'm thinking not to close it.
I wouldn't. I wouldn't. Why? Because the rate of infection will be much higher, especially that you will put a double G. That's right.
I was thinking of doing a ureterostomy. Maybe I get away with a vesicostomy opened at least for the 3 months.
You know, we don't do enough in pediatric urology. We don't do enough urethral metrophenol.
Yeah. Oh, yeah.
And it is really for us. It becomes for this uropathy patient with transplantation. It becomes really a good option because it is we have done now many of them, and some of them they remain really long time with it. Some just to cover this gap of 2 or 3 years, and then after that you just remove it. I mean, you can do it simply inguinal, or you can do it even umbilical Mitrofanov.
That's a good option. Thank you.
في كذا سؤال برضو على الفازايكوستومي and the effect of vasectomy على الcompliance والbladder function. What is the effect of vasectomy on the compliance and bladder function?
I think
your
you,
advices for avoiding affection of the bladder function in doing vasectomy.
I think all the papers which did this work showed that when you do a vasectomy, you don't affect the bladder function in long term. If which is totally different from high diversity. Yes.
كده سؤال على الفولو اب في العيانين هم succeeded valve ablation. البلان ايه في الفولو اب؟ هل انا اللي بعمله ولا ببعته نفرولوجي؟
So we have a system that they are in the first year we see them every 3 months, especially the nephrologist. But all valve patient has to be presented in the multidisciplinary meeting. We have a weekly meeting with nephrologist. And then we have a tracing now, which means that we have the cohort of the valve patients, and every year we look at this to see in the files in the database if it has been missing pediatric nephrology or pediatric urology. I think it's really, you have to work together. There's no way. I mean, it's if you can work together, I don't know how can you work together, but you have to. You have to. I mean, in the hospital, it's easier, but even in private practice, you have to find somebody that he can really try to make with you, even in private practice. I mean, a meeting once per month, even, to see all these patients together.
في سؤال من الدكتور محمد عمران، لو احنا حصل traumatizing valve ablation and urethral structure, you proceed for urethroplasty ولا نعمل diversion ويمشي على مثلا مترفانوف او حاجه؟
Temporary diversion, yes, but you have to do something for this urethra. You are not going to leave him like this.
في سؤال برضو على البوتوكس.
Very bad situation.
We face sometimes.
We had it once.
Yeah.
And the slide that you showed, Dr. Ala,
Yes.
you did a urethroplasty, a perineal urethroplasty on.
Oh yes. I did a resection
exactly like this one, but the problem
they heal very good.
Yes.
Because you have a polyuria. So they heal good, but you have to close the vesicostomy at the same time.
Yes.
This is important. But I mean, if you cannot, you have to leave them on perineal urethrostomy because they have to have no resistance to their bladder.
role of empirical anticholinergic in delaying myogenic failure في الأطفال اللي عندهم normal pressure bladder. يعني would you prescribe anticholinergic empirically for valve patient بnormal pressure bladder to delay?
Yes, for us we do it when exactly the algorithm that I showed you. If they have symptomatic, and then we do video dynamics, and then it's a hyperactive bladder. Because some of these patients, they don't. But if it's a normal bladder, no.
Normal bladder, normal pressure bladder. Would you opt for anticholinergic?
No, you wouldn't do this because you have to be careful with anticholinergic. You know that before we were just till now. I mean, everybody's giving anticholinergic long time and telling the parents there is no problem, they take it and all this. and to start now to have studies
Totally
on the
agree.
cognitive anomalies and disorders of this in adult even when you use it too much. So we
So it's not
we
a
are waiting
statement.
for our national study to see, because our national study, it's early the reaction to early anticholinergic, which means from 3 months of age, if you have something which is wrong in your video dynamic, you put him under anticholinergic. But it's a prospective study, prospective randomized study, national one. So we will see. It takes usually 3 years to understand, to know something.
There is a question about the role of Botox injection in cases of valve bladder syndrome.
Yeah.
Is there a rule for Botox
you mean
injection?
intradetrusor? Because we had a study before intradetrusor, because we had a study with the late Professor Mukhlis, and he had an idea that we injected Botox into the bladder next instead of having the
incision.
Yes, and
And what was your conclusion, Mohammed?
It was like a water. It didn't do anything.
Yeah.
Yes. Don't do
The question is not, he asked about, is there a rule for Botox in retreatment of posterior valve?
The bladder.
It is not proved at all. Normally, it's not proved. It started to be in the vesicosphincteric dyssynergia, that we put it in the sphincter, not in the bladder, but which is a different pathology.
Something different, yes.
Different pathology. I don't use it for
Thank
the
you,
bladder.
Dr. Ali. Thank you very much.
وجبة دسمة جدا. شكرا يا دكتور علاء.
Okay. Thank you very much. It's always very rich to listen to you guys. And with all the patients that you see, why don't you do just 2 centers study, and you will break the Congress. If you do a serious 2-center study, just 2-center study, and then you will have the best. I mean, what you have done, we did the review, and you will see it. I will send you the PDF. It is in French, but you can see all the reference, and you will see how many papers are coming from the recent one, which is done by Ahmed Helmi. We referred it to it as a reference also about valve. The one from Alexandria, the one from قصر العيني، the one from Asyut, the one from طنطا.
احنا هنبعت لك محمود صلاح يا باشا عشان نخلص القصه دي.
يا احنا منتظرين، وزي يعني اكتر من ميسي يعني ساعات.
مطلعين عينه يا باشا.
مش داعي بس قدام الناس كلها، خلينا بيننا وبين بعض.
شكرا يا دكتور علاء.
كبير جدا، اخذنا من وقت حضرتك. شكرا جزيلا.
شكرا على وقتك جدا طبعا. شكرا جدا على وقتك.
شكرا. الف شكر. متشكرين خالص. ساون طيبين.
شكرا يا هيثم. على خير ان شاء الله.
مع السلامه يا جماعه.
هيثم عايز يقول حاجه بالتالي.
اتفضل يا هيثم.
عايزين نعمل اناونسمنت على الهايبوسبيس ورك شوب ان شاء الله في المنصوره يوم 17 و18 مايو ان شاء الله. هتبقى منصوره نيفرولوجي سنتر. الجروب اوف بيدياتريك يورولوجي زمايلنا دكتور اشرف حافظ ودكتور تامر حلمي ودكتور دوابه، واحنا هنجوين ذم ان شاء الله. وكل البيدياتريك يورولوجيست يعني والبيدياتريك سيرجنز في مصر كلهم انفايتد يعني ان شاء الله انه يبقوا موجودين معانا ان شاء الله.
شكرا دكتور هيثم على مجهودك، طبعا كلنا بنشكرك الحقيقه. نشكر
المجموعه كلها. وشكرا ليكم كلكم يعني. شكرا جزيلا. شكرا. مع السلامه.
شكرا. مع السلامه.
مع السلامه.